Hello, welcome. We're going to talk about our first day at IQ Laser Vision for RLE surgery. So first thing you see here, we're doing biometry on patients who have not had their biometry performed. So this is very easy. We do this before we put any drops into the eyes, and we do the scan. It takes about 5 minutes to perform. This way we can get a printout of our lenses and start planning the surgery for astigmatism correction, correct presbyopia. If the patient hasn't picked a lens yet, you don't want to give them sedation until they've picked a lens and signed their consent forms. But most of our patients, I think we've agreed, have had the scan prior to surgery and surgery day, and that they've signed their consent forms, and they may be arriving pre-dilated with a 3 ml Imprimis tropyphen eye drops that they're directed to use prior to arriving at the office on day of surgery. So let's assume the patient's dilated. I come in and say hi to the patient, and I perform a full exam on the patient. My attention is to the cornea. Any scars, guttae are important to note. Guttae are sometimes progressive, so we kind of caution against using multifocal lenses. And I'll go over, if the patient chooses a multifocal lens, the downsides, which are going to be rings at night, as well as contrast sensitivity decreases. I'll also note any retinal findings. And before I enter the room, I've usually reviewed the patient's charts and all the scans. So I have a fair idea of what lens would be best for the patient, but typically all of that is already planned out ahead of surgery over the phone and in person. I'm also looking at the density of the lens here, so that helps me plan the amount of energy that I would potentially use. Typically I use 0 energy and just do phaco aspiration, but in dense 3+ NS cataracts, that'll inform me to tell the techs to give a little bit of, or have more viscoat on the side so I can protect the cornea. The whole goal is to have clear cornea the next day, and that's what makes us special. And then afterwards, we talk to the patient about expectations during the surgery. So I'll tell them, don't expect to have any pain. There might be some light pressure, big bright light ahead of you that you'll just stare blankly at. Then I'll tell them about the sedation. The MKO melt goes under the tongue. Try not to swallow it, just let it melt. And then in 10 minutes, we come back and we ask if the patient is feeling well sedated. If not, we don't do an extra MKO melt because the ketamine typically will give some kind of euphoria and goes against the effects that we want, which is sedation. So we'll chase with benzodiazepines such as Xanax. I'll tell the patient that they can expect to see halos and for the rest of the night because of the dilation, the edge of the lens. So here we're looking at preparing the Lidocaine Gel that goes over the patient's eyes. We'd want to use this in the examination room that we were just in. So this has dilation eye drops infused into Lidocaine Gel, which you see we're putting into a medicine cup here. And then there's a quick little formula sheet. So 5 mils of gel to 34 drops of 2% tropicamide, 10% phenylephrine, and then 16 drops of moxie, fluoxetine and eye drops. And then we stir it up. And then we just draw about 0.2 cc's and then put it into the eye. So the gel will hug onto the eye and have more duration in contact with the eye, as opposed to dilation eye drops, which tend to just flow off of the eye after a few blinks. This also coats the cornea and protects it from betadine later on during the prep. Just to finish up on the patient section, we tell the patient the next day they're going to experience about 80% improvement in their vision, and then the rest, that 20%, will come over the course of the week because of neuroadaptation, because of swelling on the cornea. So just expect a little bit better in the next day, but not fully there. So it's very important to have these expectations discussions prior to doing the surgery. And I'll mark the patient's eye if it's a toric case, but we always correct the astigmatism in one way or another on abscess incision, LRIs, but I typically would just mark for toric lenses, because that's assuming we're at a certain level above, LRI, astigmatism correction, that accuracy matters, and little misrotations can have a larger impact. Here we see the Statim 5000, which is how we are sterilizing. This is a wet steam autoclave. The cycle time is about 5-6 minutes, I believe. Very, very quick. Very, very compact. These are the sterile strips. So we ideally would like to see the bottom left corner strip, but I think anything on the left side there is good. But when you show me those strips, I will probably ask for it to be re-steamed if I don't see that black line all the way across. So here we're, and those strips need to be logged into a book. And it's very, very important that they're logged into a book with the lenses that we used. That way, when we're looking back and investigating anything, we can show that, yes, the instruments were, went through a proper autoclave cycle. Here we're getting started prepping the instruments for the surgery. So you can see this is a pick pack, probably from Alcon, that's going to contain, I think, the gowns, maybe the gloves, some of the prep. I think this may just be a prep tray. But you'll see, I won't need all of this for my surgeries. The prep, I do it a different way, which I'll demonstrate later. Here we just see our staff putting sterile disposable equipment onto the surface of this tray, later to be organized and arranged to facilitate surgery and the steps of the surgery. So we're going to put on microscope handle buttons, and it's very important for us to have this organized. And what I suggest is having big Ziploc bags where you store all the disposables for each case. So you can go to the storage room, aliquot into each Ziploc bag, and each bag is for an individual eye. The blades, the viscoelastic, the Tegaderms, the wet cells, anything that's loosely packaged and not in a pick pack can go into a Ziploc bag. That way, our techs aren't hunting things down in between each eye, and we can speed up our process. I think that's really smart. One of our techs during this day had pointed that out and suggested that, and I thought, I've never seen that done, but that is a brilliant idea. So that can be done the day prior, or you could even do it for the month if you have multiple surgeons or multiple OR days for RLE. Just have all those packs, assuming it's the same preferences. So I've sped this part up, but we drop off everything we need to prepare the surgery: syringes, cannulas, gloves. We'll have a list of all this stuff for you. And then later on, we're going to show you in more detail how this is set up. You'll see later on they're going to set up the Phaco machine, but we'll spend more time going over the details of that shortly. So we're just putting on gowns here, and keep in mind this is, I think, our first time the staff are doing this, and this might just be a mock run. So we're just taking things easy. We're explaining the steps. And pay attention to gloving here, and she does a great job in gowning. They're both very, very experienced. Later on, we'll spread out the instruments and I'll show what order, and we'll demonstrate during the surgery. I'll overlay the actual surgery and what I'm doing and the instruments that I'm using, so you have an idea of which instruments go to which hand and in what order. But after a few times with us, all these surgeries look exactly the same. So after you've seen a few, you just know. And there's really only 4 or 5 steps when I do the surgery, as opposed to the 8 that's usually done. We kind of make things more efficient. And there are a couple of instruments which you'll see later on that are very similar looking. You have to really look under the microscope to see the differences, but they're going to be the chopper, the Nagahara chopper, the Sinski, and the Kugelin. On this day, we saw that the Kugelin is titanium, so it's blue, so that's easy to differentiate. But to keep things easier, I recommend using some just a little bit of electrical tape at the end tail of the chopper to differentiate them from each other. And then just remember, red is maybe a Sinski, and green is the collar button or something, and then the unmarked one will be the chopper. So again, sorry, just speeding through so you can kind of see what we, part of our training process on the first day of surgery. Our Mayo stand is pretty small, so we put 2 together like this, but you may have something larger, and you can put everything all together. I think it would be very, very convenient if instead of handing off instruments to me, you just put them in order like they're doing here, and then I just grab from the tray. I stand during surgery, so it's very easy for me to just kind of take a step towards, grab what I need, and put down what I just used. Again, it's about 4 or 5 steps only, so there's not too many handoffs during the surgery, and whatever works best for the team ergonomically. As you'll see later, the space is pretty tight in this OR, so it would be hard for the tech to stand in front of me, which is normally where they would be. In this OR, they stand behind me, and often they're stretching to hand me things, and I worry that after a day they're going to have a pretty sore back. So if you just put the Mayo tray somewhere close by, I could just grab things. At some point later on, I'll lay it all out, what instruments, but essentially there's only 3 scenarios. There's astigmatism correction comes first, so we do LRI, and that'll be noted in the op plan, which is taped onto the microscope, which we'll demonstrate later.
Will you walk us through and explain
lenses,
what you're doing? Okay, so right now we've got the cartridge. We have a condom tip for the end.
Blade,
I'm going to put a little BSS on the
we make our incisions.
Cartridge, only because the cartridge is plastic. You have no idea how long it's been in there. Plastic just like the truth is, if you were like on a mission trip, this lens would probably express just nice and smooth with only BSS, but we're not going to do that because we're not on a mission trip, and we're going to use viscoelastic. Now, I like to, once I do get the BSS on it, I want to shake it off because then it affects visibility of how I see my lens. So then I need to put my little condom tip on. And this is very similar to a lot of technology back in the day when AMO, now J&J, had 3-piece lenses. Theirs were white. They had the little blue tip. This is like with scrubs that are older. They're very used to seeing this sort of thing. I want that already on. Then I need to go. Sometimes this one's a little bit tough. Sometimes they come out nice and easy. Other times it takes a little effort. Then we need to find our lens. Also, too, like we know this is only a 16-7.5, so it's going to be a pretty much standard thickness. Okay. Our lens gets a little thicker, so it have to be a 28 or a 30. Just going to behave a little different because it's thick. I'm going to take out our lens. that down. Our lens has a positioning hole and a little notch. So once I find that positioning hole, that's to let me know that when I put that in the cartridge down and to the right, I am in the right orientation.
Can you show them the way I want it?
And can you? Yes. And so if you did this and then we'd have the hole up in the what I would call the top left, because I'm always looking down at the cartridge. All that's going to affect is where the surgeon wants to rotate it. And so depending on what orientation he's shooting for, this could be beneficial or this, but I'd want it in that orientation.
Okay.
That makes sense?
Yeah. Yeah.
So the big part with our lens is the viscoelastic. There's some technique to it. You're going to put in the nose cone. Like I always say, that once you can put it all you want in the nose cone because it doesn't get in your way.
Yeah.
And there's a little more BSS. But the troughs where the lens are going to go, I'm only going to put one line.
Okay.
And that's only so the lens, viscoelastic will make your lens ride up and make your job more difficult.
Okay, so just a little bit.
Yeah, just a little bit. That's all you need. And then the backdrop, like when I'm looking for that positioning hole, this is what we were kidding about, because for me, like, there it is, I found it. So I need to go,
to get into the bathroom?
So you're putting it back the way that...
Oh, you want it your way? Oh, you want it your way?
Your way, yeah.
Okay, I'm doing it my way, which is down and to the left.
Okay.
And then the choice is either to do it up in the air, but the key is to be able to manipulate these wings, because as I make the lens go down into that trough, the hand starting to bring it up catches it and makes my job easy. Though I'm sliding it back and forth only as I just like to see that it's in and it's caught. Once it's folded, do you have to receive pollination?
It's in Carlos's direction.
So at this point, I'm going to push it. I like to hold it where I can actually see up against fluorescent, because when I put it up against fluorescent light, oh man, I can see the whole thing. And like right now, that went in so smoothly. Like even with a gun to my head, I would trust, like, is that going to come out intact and correctly? So I would say, yes, it is. And it's only because I saw that.
Can I get a chance to, because the fun you're on,
and so, and always to just, not let energy build.
You guys still would anti-step?
Makes sense.
It's nice. It's a nice one.
Yeah, but you don't want to let, like a lot of times when people, I have experience with this with other monofocals, and to let energy build, if you sit there, I think it's better to just kind of like putting a small child in the pool. Just keep winning. Yeah. If you stop, then it can kind of, like that one,
catch.
And I only bring it up, you probably wouldn't experience that on anything above maybe at 26.
Okay.
But you still just kind of, it's a leap of faith on your part, but you don't, because what happens is our nose cone tip on that cartridge does expand.
Okay.
And so if you stop and you just sit at a certain point, then it's going to expand with the lens, because it's like a gardener snake swallowing a slug. That plastic is going to be expanding. I just think they come out smoother.
Okay.
Never stop.
That's perfect. That's good.
Which takes, I get it. I'm not the one doing it. Where your tendency would be like, wait a minute, I want to make sure that everything's right.
Perfect.
But the smaller diopters should come out.
Okay.
I'm just right here.
Yeah, so this is our rep from J&J and Michelle explaining how to prep the preloaded Johnson & Johnson lenses. So that's going to be your iHands or your Odyssey.
So what I want to share with you is,
any three-piece lens other than the light adjustable lens.
Understand the model name being DI-BOO or DIU, for example. The device is the Simplicity preloaded device. Confirmation of the serial number, the diopter is all going to be on here. So when you do maybe like a second, third timeout, that's where you'll get added confirmation of the correct lens compared to the box, compared to the charts, right? So that's just all for you to know. Now, you can feel free to open this box. but you'll see that the lens is in a single sterile pack. Okay, so opening the lens now. So script tech in a circulating pack, I think is your typical kind of organizational structure, but your circulating nurse will open like this and hand it to the scrub to grab it. Okay, we don't advise to dump it on the table. Okay, so now that you have that open, I want to point out there's 3 basic steps to operating the device. So first, we're going to hydrate. Okay. Second, we're going to advance the lens. And then third, the surgeon will deliver the lens. Okay. So step 1 is very critical. We cannot operate this device without hydrating the lens. Okay. So you could either keep it in its plastic tray or take it out of the tray, but you're going to use your hydrating medium. So it could be either OVD or it could be BSS. Okay. It could also be a combination of the two. And often it's really just surgeon's preference. So we'll talk to the surgeon ahead of case and we'll confirm. But the device is hydrated by inserting into the this hydration port here, okay, with the cannula. So in this illustration, you'll see that we've color-coded the cartridge here red, just to kind of illustrate that. Okay, so you always go in, through this hydration port. You're going to fill up this entire space here with either medium, correct? You never insert your cannula here and try to hydrate in this manner, okay? Okay, so why that is important is because we don't want to backfill into this space where the lens lives currently in a dry environment, okay? So, again, you always enter through this hydration port and you fill the entire space, keeping it horizontal the whole time so that you're not letting it backflow or it doesn't tip down, drip out the distal tip, okay? So that's your critical first step. This is just a demo, so pretending that I just hydrated. The second step would be with a nice firm forward motion. I like to just use the palm of my hand. You move the plunger forward, okay? You hear the two sides hit each other, and that's good and it's fine. And then you do a half turn clockwise to get the plunger ready for step 3, which is the delivery, okay? So I'm going to have you using OBD.
I love this because I think a source of potential sterility issues is when the gloves, like mine or the Tax glove, comes in contact with the lens. Because if there's something on your glove from like working for the last 10 minutes, you can get it on the lens, like goes in the mouth. So that's why I love the preloaded lens.
That's a great point.
Yeah. And that's something that we want to convey to the team as well when they load like the clear view or the Alcon lenses. Like never touch the lens with your gloves because it's not like a damaged lens, but it's a sterility issue.
Yeah, and you also don't want to touch like the cannula, or pretty much anything that's going to get anywhere near the eye to trying to touch that. They need to clean it up and use like a wet cell, actually wipe our eye.
That's beautiful. I love it.
Well, we got great surgeons here. Sorry.
Anyway. Fill until
here. Just see it get to the distal tip, and that looks good to me.
Wow.
Okay. So now, before you pull that out of the tray, I want to just say, don't lift it from the plunger edge. Grab it from this really nice rigid part of the device. Exactly. Yep. And then, like I said,
and always keep it horizontal as well.
Correct. Yeah. Now do a half a turn clockwise. Yep. And now you leave it horizontal on the Mayo tray, and the surgeon will be ready for delivering it into the patient's eye. So again, I don't want to see, like leaving it in like a cup, for example, for the surgeon when they're ready, or, cleaning up on an edge of something such as that. So again, just horizontal on the Mayo tray.
So give me 1 second. Oh, they each called the
Okay, so
and we have Ashley from
Lens,
Alcon explaining how to load the Alcon
lens loading
lenses.
forceps.
Some of these will be preloaded in the future, but here I think we're showing a Panoptix. So that's the Monarch cartridge, and then that goes with the Monarch systems. Just keep in mind there are 3 different sizes of cartridges. Typically, I think we use the D cartridge, but if the lens is above a certain diopter size or thicker lens, we go to the C cartridge.
Dotted viscoelastic right on the surface of the lens.
I think very soon all of these lenses will be preloaded in the autonomy delivery system. So
some viscoelastic on the optic just helps prevent
just for now
sticky haptic. And then the dot out to the periphery is simply just to anchor the lens to get a good hold of it.
It sticks there.
Okay. So now what I like to do is I like to teach people to just grab the lens right at the haptic optic junction. Make sure not to go across the center of the lens. You want to protect the optic at all costs. Okay, so now that you've got your lens out to the periphery here, you're going to load the cartridge with ProVisc. Just the back half is plenty. I like to say from the wings here on back. No need to overfill the front part of the cartridge. This can be done at any point of the procedure. Okay, I'm going to get a nice grab of the lens at the haptic optic junction. And then now the goal is to get both of these haptics, the leading haptic and the trailing haptic, on top of the optic and fold it into the cartridge. So I'm going to use the wing of the cartridge, tap the leading haptic on top. And then I'm going to place it right in the back of the cartridge. Make sure the orientation of the lens is, this trailing haptic needs to be right at the corner of the cartridge. In other words, you want to prevent the lens from going in the cartridge off axis. So I'm going to go ahead and this is correct. Can you see it here? Okay, great. Okay, so now from here, I'm going to close the forceps and go all the way out to the tip of the trailing haptic. I'm going to fit the haptic right in that little notch of the forceps. Place it on top of the optic, and then in one motion, just push all the way forward until the forceps stops. And at that point, the lens should be nicely wrapped up. You don't see a leading haptic coming out straight, a trailing haptic coming out straight. Looks perfect. And then I'm going to place the cartridge right inside the injector. Push the cartridge forward to lock into place. Advance the plunger until the threads engage. Give it a twist or so and then hand it off.
Thank you so much.
You're welcome.
So now we're back in our clean room. We've sterilized a tray of reusables, and we're going to deliver this onto someone who's very hot. So just be very careful. Somebody's going to hit their head here, and then the circulator will open this tray up. The circulator should be gloved. I believe this is a mock one. Gloved masks must be on at all times in the clean room as well as in the OR. So everybody should have booties, masks, gloves. We don't want any aerosolized bacteria floating around. This must be very, very sterile. We must treat it with utmost respect for intraocular surgery. This is not, so I know this is a mock trial because we don't have the microscope handles. We don't have have the Phaco probe in that tray. So that tray will be completely full with instruments. Again, this is the mock trial, so you'll see a lot of ungloved hands floating around and people floating around. So don't worry, this is not for a patient.
Okay, let's.
Yes. So this will just be a bit of a repeat of what we showed earlier. Yeah, those are my preferred blades, the Beaver retractable blades. They're very safe because you can protect the tips. What I've noticed with other manufacturers is they don't have that protection, and the two downsides is sometimes the blades will come into contact with the tray or other instruments, and they'll be blunt before I even use them, and it's really hard to penetrate the cornea with an even slightly blunt metal blade.
1 millimeter to my left hand, 2.75 or 2.8 to my right. Then you're going to give me do you guys want to do that transfer, get the lidocaine into the... Okay. Lidocaine will go into the TB syringe.
So I'll narrate through the order later on when we're actually doing the surgery. So I'll just explain a little bit more during the transfer. Just very briefly, you're going to take the sterile syringe, you're going to put a 18 gauge needle on top of it. Usually the circulator will have the intraocular medicine, which is always preservative free. And the first one is going to be lidocaine. And the last one at the very end is going to be moxifloxacin. So here I think they're transferring the lidocaine, and I believe on this day we didn't have preserve-free lidocaine, so we used Epilido. And anytime we use anything other than lidocaine, like Epilido or Lidofen, the patient tends to be somewhat dilated the next morning, so that's not super ideal. I typically reserve those for small pupil patients, which is rare for RLE. So we generally want to just use lidocaine so they can have, pretty good reading vision by the next day after surgery.
Okay.
So yeah, typically we'd wipe with alcohol on the surface of that, and then draw it up. Lidocaine, I'd say just a little bit, maybe 0.3 cc's there is good enough. And then just be careful not to stick yourself when you're taking that 18 gauge needle off, and then you want to place a 27 gauge cannula on that. And then if you have stickers, you can put a sticker that says lidocaine on that TB syringe. Now I'm going to just speed through a little bit more here, and
sorry, I don't recommend this. Yeah.
So just to describe a little bit to that BSS, still print out bubbles.
Oh, nice. Really cool. Yeah. Okay. Yeah, perfect.
When you put that together, just
yeah. Usually you'll prep it in however you like to, but this time we'll just prep it in the way that in a sequence that I'm doing surgery. Cool. So then we'll do that, and then after that, we're going to do the capsulorhexis. So you're going to hand me the capsulorhexis forceps, which are not on the tray. They're probably outside. Can someone...
Right here, on the tray.
And the Nagahara, so the chopper. One suggestion is to organize this so that all my instruments that I normally use are together, and then all the extraneous ones are elsewhere. That way, because they all look the same, and yeah, perfect.
Yeah, people add trays closely. Use that. You can use that with Mayo and further.
That's great. Perfect.
I thought you don't need these.
I don't. Yeah. So after this, I'm gonna need the Nagahara here and the capsulorhexis forceps. So you can help me find the Nagahara, the chopper.
Chicken willing. Yeah.
think that's a collar button.
Okay.
Oh no, that's not my instrument.
You can just take out the plastic. How would you?
Yeah, this shouldn't be on this tray. There's one else. Yeah, that's the one. Yeah,
Is it long later?
I think that's a battle or something for ICLs. Yep, perfect. So you'll hand these two to me, and I'll hold on to this one till pretty close to the end of the surgery. So I'll hand that one back to you after I'm done. Then you'll give me the chain cannula, which is this angled cannula here. What is this difference? But this needs to be on a 3 cc syringe with half filled with BSS. So filled to about 1.5 cc's there. And the BSS we usually just pour from the from the machines. So for now, let's use that just to simulate. So we'll put sterile BSS in there. That you would use. To connect the.
How many? 3?
No, just one. Yeah, 1 or to 1.5. Yep. I have small hands, so if it's 3, I can't engage the plunger.
Okay. This.
Yep, that's right. And then let's prime that. Perfect. And then, so that's next. That's hydrodissection, so freeing the lens from the capsular bag. The next thing we'll do is the Phaco probe, which should be on this tray after sterilization as well. But let's just assume that was sterilized. And do you want to take over, Ashley?
So Ashley is going to talk to us about how to set up the Phaco probe, how to put the needle on. I think the needle, be made out of metal and plastic, and the sleeve, which is silicone. I think we can reuse those over the course of the day. That avoids the problem of having to put the needle on after every case, getting the sleeve just right so it's not covering the ports. Which is something that we struggled with because we didn't have a magnifier in this room, and our techs weren't able to visualize the level of the sleeve. So we had one case where the port was blocked, and of course the microscope wasn't clean, so I wasn't able to see very well during the first couple of surgeries on the first day that we were doing this.
Induction battery back
and
here, so you want to make sure it's once your day's over.
So for the IA probe and the Phaco probe, we can just use in the beginning of the day, put on the sleeve and the needles, and just keep that throughout the day, and then unscrew it and throw it away at the end of the day. The autoclave will fully disinfect everything after, and we'll just clean and flush everything between each case. So just use them as reusables.
The Phaco machine for pedals always to my right side and the microscope to the left. Because we're using this Visumax bed, one of my legs will be off to the side, so this one will mark on the floor where best to put it so I can reach it. Can't fit under
it was very, very awkward to perform surgery sitting because the headrest here is, I can't stick my legs under the headrest, so we had very awkward positioning. What we decided to do was raise the headrest, raise the bed as high as it goes, and raise the bed itself with firm mattresses, firm pads, such that I can stand next to the bed and perform the surgery. That way I can have the foot pedals together. I'm more used to operating standing, so that's the go forward.
This is our technical services number right here. If you ever need anything or an advisory comes up on the machine and you just want to talk it over with someone, you can always call myself. I'll make sure my card's on the machine. This is also a good number to know. Okay, so you have the side pocket as well. This is typically where the remote control is kept when the day is over and the machine is asleep. So we'll keep it up here as well. So wherever you decide is the remote control. There's a secret component here as well. This little silver drawer. You just twist the knob and it opens. This is where a foot pedal board is kept. So the foot pedal is wireless on the Centurion. and it's powered up on the back of the machine, but just in case it wasn't powered up, it doesn't have enough batteries, you can plug it in. So you just plug one end into the front of the foot pedal right here, and then the other end will go right here. Okay. Don't expect we'll need this. But I want to make sure you know where it lives, just in case. Okay, so here's the side pocket. This is also important to note. This is where the retractors are kept. So if there is a need, there's always typically one or two kept in this side drawer. So that way you don't have to run around and try to find one in the center. They're kept right here. Okay, so you all like your machine twisting around. This right here needs to be swept out of the way. So you do so by pressing down on this disc, and then this tray moves to the side. You can move it really wherever it's convenient for you. A lot of times people keep drops up here for after the case, or bags of BSS, they kind of stack them here, 5 at a time, or however you want. This drawer right here is where the BSS bag goes during the case. Okay, so that's the first thing you'll do. Typically the circulator will drop the bag in and close the drawer. You can't prime the machine until this car is closed. So it's really just a nice, efficient thing to do. You drop the bag in on this little hanger and then just close the drawer. That way you don't have to think about it again. Let's swing this around to the front. This tray just comes right down. You can swing this in a lot of different directions, wherever it's convenient for you. If you want to make it compact, you can also use it like this. Depending on, your comfort level, you can increase or heighten that.
That's short.
Okay, so looking at the face of the machine, this is for cautery.
Well, not till I ever need that.
This is a light right here.
Oh, that's it. Let's see it down there.
And then there's a light you can turn on and off just to make sure that you're putting a tip on correctly, or a sleeve. That's where the light lives. This is for that little anterior retractor kit that lives in the side pocket. And the cheat sheet will come up on the machine. We can go back there. And then this is really for your Phaco handpiece. The handpieces you have in-house will go in either one of these two. Okay, so for the machine, we have our machine cassette right here. Comes in your, Alcon calls it a pick pack. It's basically that bubble wrapped little pack. Yep. And then, like I mentioned earlier, your BSS bag. Those are really the two kind of disposables that are needed for your machine. Then you have your Phaco handpiece, which we'll go over setting up, and your INA handpiece.
That will go over as well.
Okay, so ideally, this would be opened on the back table as well. And inside, there is a cover for this tray.
This part you want to pay attention to because, yeah.
Okay, and there's a couple tricks here that that will become important just for your setup. So once this cover is on, whenever it's on sterile, you pull this out and just create a nice pocket for yourself. This is where your hand pieces will live. This is where you'll let some BSS free flow for your syringe for hydrodissection. Okay, so got this set up, and then we're also going to put the remote control under here as well. Now these do stand, so this will be here, if you won't move this essentially off and on. Okay, so here's your remote control, here's your pocket. And next inside your tubing cassette is your sleeve kit and your tip, and Phaco tip.
Oh, sorry, I was just going to interrupt. I don't use pink sleeves. I use purple sleeves.
Yes, you have purple sleeves in yours. I brought this
thanks.
in, so you didn't have to
Okay, yeah. Don't give me pink sleeves. Thanks.
These sleeves fit with the incision size. So purple sleeves are what come in your kit, and purple sleeves fit a 2.8 millimeter incision, which is your blade. This fits a 2.4.
Let's go a little bit smaller.
Yeah.
So
So you have your sleeve, you have your test chamber, and your phaco tip. Okay. And then your machine cassette. You just want to grab it right from the handle here. And then you've got your tubing. So the first thing is you're going to take your machine cassette and angle it on the bottom of these bars and then tip it forward. And your machine will grab it from you. Okay, so then you're just going to dispose of these little paper pieces here. And put them in your trash bag or throw them in there. Okay, so what is included here is your, this is for the VSS bag spike. Just remove this. You can do it yourself, sterile, or you can hand it off to your circulator. And then you'll stab the
first, let me do on
VSS bag.
Statim. Good.
Yep. Make sure it's nice and tight. And then, as you notice, the machine tells you, kind of prompts you, it gives you a nice cheat sheet on what to do next. I always ask people to separate the line, just more comfortable for your surgeon, and then you connect the two tubes. Okay, so connect that line, connect the tubes, and then the machine's ready to be primed. You notice on the screen, there's a machine cassette image right here, but it's red. It means the machine says, yes, we've got a cassette in it, but it's not primed yet. It's red. So we're ready to go with prime. You can do this a couple different ways. I know in your pick pack there, you do have a screen cover. So this will all be sterile for you. So you'll be able to touch the screen. You can also do it from your remote control. Maybe you're not right next to the machine and you want to go ahead and ask the machine to prime. It's this enter button right here. Yep, so you're going to go ahead and hit enter, and the machine's going to prime. Fluid's going to go all through. It's going to check about 200 different sensors. And make sure the machine is all good for you. In the meantime, while the machine is priming, we're going to set up the phaco hand piece. Okay, so the first thing is we're going to go ahead and just remove this cap. It's a collar right here. You just pull back on the collar and the cap pops off. And then you just match red dot to red dot. You push it in until you kind of hear it click. Okay, and then you've got your hand piece. I'm going to take the phaco tip. We're just going to connect it right into the hub of the hand piece. And we're going to twist until it stops. And then you're going to give it one little more twist. So it's just so it's nice and finger tight. And then just rock the wrench right off. You're going to need this to take the tip off. So just drop it in there typically and save it for later. And then you're going to take your purple sleeve. It's not pink. And you're just going to feed it right over the tip. This is where a light could come in handy. You guys are a lot younger than I am, so you probably see it just fine. The key to setting this up, though, and putting the sleeve on, I do want to show you guys. There are two holes on the tip of the sleeve, and you want them to be really facing east and west of the curve of the phaco tip. Okay, so you want the holes to be on either side of the bend. Does that make sense? Okay. And then most of the time you want about 1 millimeter of the metal exposed.
Yep. So you want it as long as it is wide, so 1 millimeter from where the pink sleeve or the purple sleeve ends, and it tips the longest part of that needle. So it should be as wide as it is long. You guys are young, so you can probably see.
For the phaco tip, when we're doing it at the beginning of the day, I'll I'll come in and inspect it, and I'll put it to the right place. But you can see we're using a pink sleeve here. This is for a 2.4 millimeter incision, and 2.2 to 2.4. I don't use that one. My incisions are 2.8 millimeters, roughly 2.75 or so. So we only use purple tips for any surgeries that we do. So just keep that in mind, that if you see a pink sleeve, just go ahead and toss that. The sleeve size matters because if there are gaps in the tissue, well, first of all, if it's too big, it's not going to fit through a small incision. But if it's too small, during certain parts of the surgery, the iris can billow and plug and try to come out through the incision with the fluidics. So we want the perfect fit. So this part, we're still priming the tubing. This is very important to follow instructions. And I learned that you can press that return button to move things along. That's very convenient. So you want to fill up a medicine cup at this point as well. Fill it up with maybe 20 cc's of fluid. That way you can use that medicine cup to drop BSS. This is BSS that's flowing to replenish your hydrodissection cannulas, your BSS cannula at the end of the case for hydrating the incisions, and for diluting betadine at the end, which I like to put a drop of dilute betadine to just kill off any more bugs on the surface. I'm just very, very particular about sterility. So
keep that open.
Oh, yes, I totally forgot we did that. So yes, you'll have a sterile cup on your pick pack, and then you just want to fill that all up, to a certain point, and use that fluid for your cannulas later on.
Solution at the very end of the case for doing like final touch of sterility. So I will
prefer if you loaded that little cup rather than digging through some more in there. Yeah.
So we'll kind of redo that step. When you go to fill, you'll just have this medicine cup here. And I'll explain to you. You can launch this fill line here. When it's about 3/4 of the way there, you can fill your test chamber. Slide it on. Then you can hit the enter button one more time, and it's going to automatically go to testing your handpiece. Okay? So we're just going to leave the handpiece flat, and we're going to let it continue to test. This handpiece doesn't like to be waved around during test. It just likes to be nice and stable. There's some crystals in here, and so it just needs to go through the proper tune.
Is that an active sentry handpiece?
This is, yeah.
Perfect.
Yeah.
Okay.
Is it? So now we know our cassette image is green, good to go. Our Phaco handpiece is green, we're good to go. That means we're primed and we're tuned. And then the machine automatically puts you on the settings screen. So we're really ready to start our case as far as the machine is concerned.
Thank you. Will you go over switching from Phaco handpiece to...
Definitely. Okay. Okay, so...
Waiting.
Custom wide. Blood women. Okay, so... Oh, I have one right here for you. Yes.
Oh, okay.
Do
you have the tip?
Yes, I do. Yeah.
The gray one?
So all of this needs to be set up before surgery.
Okay, so you're going to have in that pick pack, along with the machine cassette, you're going to have this tip right here. It's called a polymer INA tip. There are always 2 hand pieces used during every intraocular lens surgery, okay? So this is referred to as a Phaco handpiece. This is referred to as the INA handpiece. It's irrigation aspiration handpiece. This one is larger, delivers energy. This one really just has the ability to irrigate and aspirate. There's no energy. So this one's used at the very end of the case. When you think of like a cataract, like an onion, there's lots of inner layers. And then, that last skin of an onion? Yeah. Okay, so Dr. Tian's going to pretty much get through the whole case with this handpiece. And then when there's that last skin called cortex is the term, he's going to ask you to switch to this handpiece. Okay, so this is going to be ready to go. What I did is I took this handpiece, similar wrench to the Phaco tip,
So
You're going to connect the two.
again, the IA tip is set up very similarly, and we put a similar purple sleeve, again, the same size incision, so purple sleeve. We can just do this in the beginning of the day and then leave it to sterilize through the polymer tip, and the silicone sleeve will be just fine through the autoclave. And this avoids us having to unscrew it. Sometimes I damage too many unscrews, as we noted on this day. Sometimes we'll break the IA probe. And so I think it's just better practice to keep it on for the day and then throw it away at the end of the day. I think a lot of surgeons who deal with more dense cataracts like, fresh tips because they're sharper. But when we're dealing with RLE, that's not an issue, since we're not really using phaco energy anyways. We're not jackhammering that dense lens because it's a soft one. When we go from phaco tip to IA probe,
you need to shove that right in so it never comes off.
Oh, yes, that's a good point. So shove that white aspiration line in because there's not lure locked. This particular Maestro handpiece from J&J that I use doesn't have a lure lock. So sometimes if that falls off, then we get into, I think that's the irrigation line, sorry. Then the chamber will collapse and we run into some problems. So really give that a good shove into what I was going to say is I can do that change. If you just hand me the eye probe, I can take off the aspiration irrigation lines and then just quickly switch it into the eye probe and keep going, so that you can do other things like while I'm handing you back instruments, giving it a quick power wash, or flushing any cannulas that are reusable. That way, for central processing, it just saves a step later on. You don't have to do much more than just put it all back in the tray and back into the sterilizer.
If we're doing ICLs, it'll come beyond ICL, but
hey, here you can see I have some other settings, denser cataracts. There's an ICL Yamani setting. You want to put me on that when we're doing ICLs. It's just taking into account the fluidics in a phakic eye, which is going to need just a little less pressure during the surgery. Otherwise, the patient can have a lot of discomfort. So everything on my settings are optimized for different surgeries. You don't have to touch anything on the screen during the surgery. I control everything on the foot pedal. So don't worry about. But screen, that's a good point. You do want to have that sterile drape over the screen just in case we're switching things or things weren't set up right, that you can go and help me kind of change the procedure or change settings. So typically we don't change anything on my energy and fluidic settings.
Never save that.
Never save anything because it'll save over my settings.
You would never change everything. Yeah, you would never change anything. You don't even have to ask me. It's all pre-programmed. So this is all set. It's set on a ramp. I control it. I control the energy with my foot pedal. So
you notice I only have 2 settings as opposed to many other surgeons will have 4 or 5 settings.
I change that. I say yes.
Everything I do is controlled by the foot pedal, so I can modulate energy, modulate fluidics just on the gas pedal on my Phaco foot pedal. So I just got used to that because we were so short-staffed during COVID that I figured it's just easier for me to
plastic cover on the screen
to do everything.
You're just do that. Oh, okay.
Pat, want to open some on your board?
Oh, it's okay. Maria, do you know how to put the cover on the screen? You do? Okay.
It's a clear piece of plastic with adhesive at the very top. You just peel off. A lot of times you can peel off half of it, stick it, and then continue to peel it off, and it'll go all the way across. But essentially, it's meant for the adhesive to go right here. Sometimes it'll put it up to here, but that really good.
Thank you. All right, so you'll take your tray here, and let's load up your. Oh, you already loaded up the. So, anyways, you'll probably use it from that. That says. Okay.
Second question.
Yeah, of course. Yeah.
Questions here. I just want to make sure it goes into.
Okay, so we got to hydrodissection with the chain cannula. Then we go to the Phaco handpiece, so you hand that to me. I'll still have the Nagahara chopper in my other hand, so I won't hand that back until I'm done at the very end of the surgery. After we're done with that, Ashley showed you how to transfer that onto the IA probe. Now, with RLE, it goes by really quick. So you probably want to be starting to load the lens.
I'm going to just make a correction that you probably want to have the lens loaded before we even start the surgery,
Phaco.
if you have time.
So by IA,
It's a very, very quick nuclear disassembly in RLE. It literally takes like 30 seconds to a minute to do. So, and then IA cleanup is maybe 20 seconds to 30 seconds. So, and then sometimes the patients get a little confused when there's big gaps in doing things, and it's an uncomfortable pause for the patient. So we really want to have a very smooth flow during the surgery, and then not to take too long. And then that makes for a better experience, in my opinion, and the patient will feel it's very done professionally, done with great care and experience and preparation.
Phaco probe. We've done the IA probe. You're going to hand me the Provisc as I'm handing you the IA probe. Yeah, so I can keep the chamber inflated. Then after I'm done with this, you'll hand me the lens, and I'll load the lens in. And then you hand me back the IA probe so I can remove the viscoelastic. And at that point, you'll need a 3 cc cannula, a separate one, with almost full BSS. I go up to 2.5 cc's there, and you put the 30 gauge angled cannula on top of that, and then just make sure to prime the tip there. Yeah, that's the one. Perfect.
Sorry.
Yep, so then I'll seal the incisions. This will go at the very end. Now, after I've sealed the incisions, you're going to mix a betadine solution for me. So what you'll do is you'll probably keep something like this, something plastic. Someone is going to hand over the betadine.
That's okay. It's the eye drop, right?
It's called the drops. Sure, yeah. They can help a lot. That's what they need. And we'll do.
I hear you see. She grabbed a little, tray. What we're doing is that's a drop of 5% betadine that the circulator will put on the something for you, and then you take the BSS yellow. You may not have a BSS dropper like that, but you'll take it on a syringe and then just dilute it to this yellow color. Anything darker than yellow may sting and be harmful to the cornea. But what I really want is just there to be some betadine on the surface of the eye after surgery, and that's we're going to be using intracameral antibiotic. We're going to hit them with the dilute betadine on the surface of the eye for bacteriostasis. We're going to, before the patient leave, watch them do a set of eye drops in their own eyes, and we're gonna before they leave the office, give them some tips on how to do their eye drops well. So we really need them to do their eye drops well for the first 5 days before the incisions are fully healed.
Except it's the Lidocaine, but you'll hand them off.
So this is almost a perfect setup. At the very beginning of that tray on the left-hand side, you'll probably, if I indicate that we're going to correct astigmatism in some way, there'll be 2 instruments there, either some kind of ring, the Thornton or the Mendez, and then either a marker or the LRI blade, depending on if we're doing LRI or toric lenses. But otherwise, that tray that you just saw is what you can put next to me, and I can either grab things myself or you can hand it to me.
Maybe 0.2, because sometimes
here we're talking about moxifloxacin, and that you'll hand to me after I'm done with IA to remove the Provisc.
I'll swell up.
So you just want to give me a little bit. I only want to put in about, I think 0.05 to 0.1 cc's, and I think it's a 0.8. I just forget micrograms to microliter to over.
So that'll be
8. It should be 1 to 1, something gram to 1 microliter ratio, and that's interesting. That's what we want to use neat and without dilation. But sometimes you'll get moxie that's a little more concentrated, in which case you need to dilute that.
Just make sure the patient knows that they're going to see dark pieces of bright lights that they were just seeing for about 5 minutes or so.
And that's really important. I had a patient faint because after the bright microscope light was lifted from the face, he said, I only see dark. I was a young man. And typically, and I think I had just switched ORs, and I had, become accustomed to my text telling the patient, I'll expect about 5 minutes of, darkness because of the after image from the bright light. But that wasn't communicated to the patient. They just thought something happened. They lost vision, and then he was unresponsive for a good, couple of seconds. So we want to avoid that at all costs. We want the patient to have a very, very feeling of safety and a good experience.
So that's for marking toric lens.
So yes, Mendez, a marker for a toric lens that you see there, and that'll be on the timeout sheet or the sheet surgical plan that we post on the tower of the microscope for easy reference.
Yeah. And then diamond blade, it'll be on that tray.
And then we're talking, so I think the diamond blade wasn't on the tray. I think it's back ordered on our first day here. So you'll see where they're going to hand me like a disposable LRI blade, 600 microns. So the alternative, if we're going to correct astigmatism, is the Thornton ring, which is the sort of the almost semicircle one you see in the inferior part, and the diamond blade. So there you go. We have a diamond blade. I think one was back ordered, but we did have one for the second tray.
So some final things that I personally like. I like for the instruments to be clean after I use them. So these are all very sharp and delicate instruments. So I need you to rinse, particularly this one, the Cancel-Beresis forceps.
So don't wipe these instruments. You can power wash these with cornea BSS irrigation. Just wash the viscoelastic off. Otherwise, during the autoclave process, it dries and shrinks and becomes this like snotty material. And we don't want to introduce that into the next eye that we're doing. But you don't want to handle the arms of the tips. They're sharp and they can bend very easily. And if they bend out of shape, I can't use them as forceps. They don't oppose each other, and I can't grasp. And that's the most crucial instrument on this tray to be perfect, because the capsulorhexis, as you know, is one of the most delicate parts of the surgery. I wouldn't even wipe like that. I would just flush it vigorously with the BSS off of your cornea irrigation cannula. You want to rinse this as well. So this is the diamond blade. The diamond blade, some people will clean and with a specific cleaner and this foam material. But I think just a vigorous irrigation will do the job as well. So just to get any viscoelastic or cornea tissue off of it. Otherwise, it cakes on after dozens and dozens of use, because the autoclave just bakes that tissue in, and then you get this like rusty looking black tip that doesn't cut well and just looks like a sterility hazard. So yes, any sharp instrument you want to rinse very well. You don't need to rinse or process anything that I didn't use during the surgery. So there's going to be a few choppers there that we typically don't use, but just have on standby.
Yeah.
And then any choppers, you just give it a quick rinse or a quick wipe with a moist sponge.
I'm not used to this position, so this one goes on the side, and this allows me to tilt the microscope. which I may need to do as I get.
Yeah, it's very important to put the sterile covers on the microscope handles.
How it goes over everything. Oh, yes. Totally. So let's talk about speculums. If it's a pretty normal patient, we'll go with the bladed speculum. That gets all the eyelashes out of the way.
That's the bladed one on the table right there.
It's the eyelashes that harbor the most germs, so we do our best to tape them out of the way. Well, speaking of that, you have the Tegaderm. Okay.
And the wired speculum is for usually small eyes or eyes with floppy eyelids, because they tend to evert and do really weird things. So you want the wire to go right into the fornix to help stabilize the eyelid. It goes deeper in and works better. But that's on rare occasions that we need a wired speculum.
Okay. I think buggy out there.
Yeah.
You want the Westcon.
So the Tegaderm goes over the eyelids and covers all the eyelashes. And I'll show this to you later on. But
we're going to be struggling for today's cases.
You want to cut that in half. And I wouldn't bother taking it off the non-adhesive pad. You just hand it to me in that way, and I'll take it off. If you take it off too early, chances are it's going to get wrinkled and like stick to itself, and then we end up having to cut more Tegaderm. So you can just hand it to me just like that, and I'll take care of the rest.
The drape looks like.
And the drape should be clear to avoid claustrophobia, and should have an aperture, so that little ellipse.
Yeah, okay. So what you'll do is you'll remove this backing, and then you'll fold it in half. The other way.
That blue strip that you see on the side is a stiff wire, and you fold that in half right through the long axis of that ellipse of the aperture. Then you hand it to me, and then when you prep, if you're going to prep for me or drape for me, you know that the blue should face temporally, so away from the patient, over the eye. That's important because there's a little bag that catches fluid, and it has a directionality. See, there's the blue little bag.
So that's the drip catcher.
The drip catcher.
So if you're prepping for me, you'll angle this
out. So I like this sterile drape. It has arrows to tell you which way to pull the drape as you're unfolding it over the patient's face.
Big area, so the aperture.
Quite big here. Other ones that I've used have been that don't have that arrow, and you have to remember, right eye you have to go down first, or the opposite. Right eye you go up first, and then left eye you go down. Otherwise, it unfolds the wrong way.
And then tape nicely around the patient's orbits.
So what I'm explaining here is that the aperture is pretty big, so you want to prep the face twice as large as what the aperture is, just in case we place the aperture awkwardly, that anything that's within the aperture is going to be sterile.
It's like a 3-pack.
This part we'll skip over, but I just show, this is what I use for prepping the eyelids and the eye, and I'll go over that in a later portion of this video. The way that I would want you to do it for me for RLE surgery. Again, the emphasis is that the eyelashes harbor a lot of germs, and that's a big source of infection. Not that infections, we should have zero infection, by the way. If all of this is done properly, it should be zero. There should not be any endophthalmitis ever.
Moxie.
And here I'm just explaining that blue vial has 5% betadine as opposed to 10%, and 5% is the highest that you want to do on the actual surface of the eye. I believe skin prep is usually 10%. Any more than that, and it starts to irritate the skin. And certainly it will irritate the cornea if you do 10% betadine drops. So
here. Yes. So we start with this for the patient, and this.
Yes. So the order will be tetracaine, followed by the lidocaine jelly, and then into the prep with the
let's see how much is in there. It's a big deal. But
that's about as much as you want to put on the eye with the lidocaine gel. And do it in both eyes.
You could. Oh, and then when you're dripping the betadine in, you want to do a drop in the inferior fornix, so, and then one in the superior fornix. You want all those bugs around the eyelashes, and in the, the pouch of the eye to not bother. Yeah. Okay, that's a lot on it.
So now we're going to prep an actual patient. So you'll see we may have already put in the tetracaine in both eyes. Oh, yes. So start with the tetracaine. It's going to sting a little bit. And then you do a dollop of the lidocaine gel that we made at the beginning of the day. Again, nothing's sterile at this point, so we've just been reusing that aliquot of the lidocaine jelly that we infused with dilation and antibiotics. And then a drop of betadine. And now we just do from this point on, we just do the eye that we're about to do surgery on. So one drop in the superior fornix, one drop in the inferior fornix. And that shouldn't hurt the patient now that they're numbed with lidocaine jelly and tetracaine. And then some will drip, and it's nice to, otherwise it might drip into the patient's ear, so you just want to clean that off before we actually start the prep.
And just have you open your eye for me. You're going to feel some scrubbing of your eyelids. I'm going to help you out a little bit. So either of the eyelids and a vigorous scrub. You want to get all of that eyelashes and all the scurf or those little.
Some people prefer to use sterile gloves. You see, I'm just using clinic gloves. As long as you're not touching the sterile field, it should be okay.
Yeah.
With your gloves, I mean. And now we go in concentric circles outwards around the eye as we normally do. And remember the aperture size of the drape. You want to go twice as wide as the aperture and longer. That way, if we miss, we don't want anything exposed that wasn't prepped with betadine. Now remember the actual exposed area during the surgery. We're not doing skin surgery, first of all. So this is nice, so that when I have sterile gloves on, if I inadvertently touch the skin within the aperture drape, that we know that it's sterile. But it's not the skin that we're doing surgery on; it's the actual eye, and the skin itself will actually be covered by Tegaderm, as you'll see later on when we show the draping of the patient. Typically if you're doing a skin surgery like eyelid surgery, you have a contact time of about 5 minutes of the 5 to 10% betadine. But in this case, because it's all going to be covered by Tegaderm, we can just pat dry with sterile gauze. So that's sterile gauze coming off of the table from our pick pack, and we just kind of pat dry around the eye and then lift that off, and that's good to go. And here we're starting to get ready for surgery. So I'm getting gowned here. Typically, I'll just pick the gown off the table myself, and then the circulator will tie me up in the back. If I'm doing standing surgery, you just do the neck one as Maria's doing there. You don't have to tie me up in the back unless I'm sitting down, because standing. The gown kind of just drapes down, and we're not exposing anything to the sterile field. And I never turn my back to the patient. But here, on this day, we are sitting for surgery. So you see I've done that spin. Yeah. So typically when we're doing a lot, or the autoclave is slow, the instruments like the Phaco tip will come out pretty hot. And I think what we're saying here is that the Phaco probe is pretty hot, but the Phaco probe doesn't go into the patient's eye. So by the time you're all set up, it's it's cooled down. The tip, as you're priming, so if we're reusing the tips, the tip is maybe hot at this point, but as you're priming the Phaco, it's pushing cold water through that whole system, so it cools it down before it's, by the time it gets in the patient's eye, it's already cold like the BSS that's in the machine. So don't be concerned that it just came out of the sterile autoclave and it's hot to handle. You can go ahead and, so here I'm putting the sleeve on. We'll probably do this in the beginning of the day. And you want to give me, with the Phaco probe, about 1 millimeter of exposed tip. So 1 millimeter bare metal. It should be a square when you look at it straight on, that the width of the needle should be the length of about 1 millimeter, and that's, you use that and just do a square of exposure. So yeah, use the width as a guide for how much length to give me. Here I'm filling up that medicine cup with BSS, and that'll be used later on to draw BSS for various tasks. And then I've put the silicone sleeve on. I'm holding the Phaco probe horizontal as it's doing its tests. So it's testing aspiration, vacuum, it's testing Phaco energy, and then it'll make some funny noises. So now if you can put the drape and Tegaderm in the front of the tray there, or hand it to me, I can then begin the draping process. So here we're going to be doing the left eye, and so you'll see I'll ask the patient to close their eyes. Here I believe there was I wasn't happy with the hair being close to the sterile field. But again, all your circulators, this is not nice to not have a gloved hand in the OR. Everybody needs to have a gloved hand, booties on, proper surgical masks. It was a soft call, but I decided just to proceed. But I don't like to see practices like that. This is also not a very great technique, in my opinion, to put a pillow on the chest. We typically have a little gooseneck device that pulls the drape well over the chest, so that there's a good flow of air. I think it was maybe this patient that had some claustrophobia during the surgery because of how close that drape is to the mouth. Here you see I evert the eyelashes, and I carefully place the Tegaderm to cover all eyelashes, so they must all be covered to give sterile exposure and good exposure. And this is something that I'll work with you on, so that in the future when you do drape for me, we achieve the same effect.
Sorry about that.
And then here's the bladed speculum. As you can see, the bladed speculum also pushes the eyelashes and covers the eyelashes, and that's the beauty of the bladed one, is that one, it's comfortable, it doesn't dig in the skin, and two is it covers the eyelashes well for me. So at this point, this eye was very dry, so I'll be overlaying the actual surgery. We don't have a camera on this microscope. As you can see, there's no camera here on my microscope. So it makes it really hard for my staff to kind of follow along with the surgery, anticipate my needs, see the dry cornea to wet the cornea for me. So I'm going to be overlaying the surgery over the screen now, and you'll be able to see. And I'll blow up the instruments as well, so you can see which instruments that we're using as we're doing the surgery. But in the audio, you'll just hear me. So what I'm asking for here, before all of that, if we're going to do astigmatism correction, I think in this case, what I'm holding is the Thornton ring, and we're going to do an LRI. So that should be written on my surgical plan, which is stuck to the microscope. So if the surgical tech can pay attention to the surgical plan for each of the eyes, you'll know how to anticipate me. So I'm performing an LRI for the patient, so that requires in one hand the Thornton ring, and then in the other hand, usually a diamond LRI plates, 600 microns or 550 microns is basically the same. And if in another case we're doing a toric lens, you'd hand me the Mendez and the marker, and that way I can mark the axis for the toric lens. So now I start with the two blades, and we do the paracentesis and the main incision, and that's done. I do them together so that's going to save a little bit of I always use two hands at the same time when possible, because it stabilizes the eye, and if the patient were to move, they can't overpower two hands. But if it's just one hand, they can torque the eye, or sometimes they can move on me. Now I'm doing lidocaine and viscoat. That's the viscoat going in and inflates the eye. And then right now in my right hand, I should be holding the Nagahara chopper. And again, this is the part where it's really hard without a magnifier for our techs to see which chopper to give me. But you'd want some electrical tape of different colors to help give visual aid to our techs if the room is dark like this, which we at this point haven't implemented. Yeah, and we don't have a microscope, so my tech can't see that the cornea is very, very cloudy from dryness. And I think that was the collar button or another instrument that was given to me. So I want the Nagahara, which is my main chopper, my chopper of choice. I believe we have 4 different choppers on the tray. So platform. And again, only I can see it with the tips in this scenario, because only I have the microscope. And it seems like I got my chopper in my left hand now, and I've got the capsulorhexis forceps in the other hand. I have a cross-action one called the Inamura. Beautiful instrument, very, very delicate though. And here I'm performing the capsulorhexis. And I think that the manual capsulorhexis is stronger than a femtosecond capsulorhexis by far. It is, by definition, a continuous curve capsulorhexis, whereas the femtosecond one are just pulses of energy. So in some places it's weaker as it tears out a little bit, and you can get into problems during surgery. I've seen other surgeons perform the femtosecond laser procedure, and I've seen a few complications during that process with the laser either tearing in the capsulorhexis, tags, or cutting the lens so deep that as soon as you put aspiration in, the lens just falls onto the retina. So for those reasons, after seeing all that, I have decided never to use the femtosecond laser. But my capsulorhexis should look very, very close to perfectly circular and perfectly sized. The instrument that I use has markings on it to tell me, what a 5.5 millimeter diameter should be. So I'm removing the lens now with the, at some point before all of this, I did a hydrodissection. And here I am phaco aspirating. I use no energy, as I said before, so that they can have a clear cornea by the next morning. And if you don't do energy, you're not going to have complications. I would say RLE, I've never had a posterior capsular rupture during lens disassembly, like never. And I've done probably like 1,500 RLEs at this point. Whereas cataracts are very dense lenses, when you chop and whatnot, sometimes you can inadvertently hit the posterior capsule. So for me, 1 in every 400 cases, we may have a PCR. But at this point, I do most cataract surgeries with phaco aspiration as well. And I don't think I've had a PCR cataract surgery since doing all premium lenses, and that's sort of the expectation in this, for this patient demographic. So the lens, typically it goes by pretty quick. I think in this case, it's a little slower. I think this was a case where the microscope is kind of foggy and dirty, and she had a foggy cornea, so I wasn't able to visualize very well. So you can see that it takes a little longer. But typically the stage takes either 30 seconds or up to a minute or so. Yeah. And at this point, you either want to put the eye probe very close to me, so as you're doing other things, flushing the instruments that I just handed back to put back into the sterile tray for the next surgery, or you're loading the lens. But I would say, that would be a good time when I'm doing nuclear disassembly to be loading the lens. Here you see that we're switching to IA. You can just hand me the eye probe. I can switch the lines out. I think that would save a little bit of time. And then we remove the cortex with the eye probe. And then next, that's the eye probe. The next you'll see she'll hand me Provisc, and then she'll hand me the lens to implant. And then this overlay that I'll provide will probably not be timed well, because again, the surgery wasn't recorded. We didn't have a camera, so I'll have another surgery overlay just so you can see what the instruments look like. Okay, fine. Well, I better speed this. So I spent a little bit more time during that part because I'm trying to remove all the viscoelastic, the viscoat. That's what causes pressure spikes, the viscoat. So I spent a good 30 seconds just going to the angle, and going pretty close to the cornea and trying to remove any viscoat that's stuck. You saw that I put the Provisc in, that's the green cannula, and now I'm injecting the lens into the eye. And that was a Johnson & Johnson preloaded lens. So that's why you didn't see us fussing around loading lenses during the surgery. Essentially with that one, you just put viscoelastic into it and it's good to go. I think here we are rotating the lens, possibly. I can't remember exactly what we're doing. Or maybe sometimes there's pieces of the lens material that come out from under the iris or something, and we need to go back and remove something else. But that's probably what I'm doing, is there's some retained lens material that we missed earlier on. So we're just removing that. And now this is where we seal the incision. So she handed me the 30 gauge angled cannula. And I'm very particular about that cannula. It has to be that cannula because anything large or anything just either ergonomically is not comfortable or it doesn't seal the roof of the incision well. This cannula, I've never had an incision leak after I've used this cannula. It's just very beautiful. I don't have to overhydrate the cornea. Otherwise, the patient will have blurry peripheral vision from that swelling for longer. And so we just give a gentle hydration over the reef with that. And that's the moxifloxacin. I put just a little bit in, and I put the rest on the surface of the cornea. And then the last one is a non-cannulated betadine, dilute betadine, that yellow betadine. And I put that over the eye after I know the incisions are inflated. Yeah. And now I'm just helping take out and here you can see standing surgery. This is the way I I'm most comfortable. I can, stand very close to the patient. It's ergonomically good for me, neck-wise, to prevent back pain. And instead of twisting while seated, which I have some back issues, it can really aggravate my issues. And also this way, regardless where the tech is, I can just kind of shuffle my feet and turn around without putting twisting forces on my back. Yeah. And I think we'll have this for our Daly City clinic by the next time that I'm there. You can see it's very, very stable surgery either way you do it. For the last 2 years, I've been doing the surgery standing without any issues, and it's been great for my back. And our techs, it frees up a lot of real estate in terms of surgical chairs, and you can do this very easily, and it avoids needing to position the chair or twisting the microscope, things like that. When your legs aren't bent underneath you, it just you can bring your torso very close to the patient's face, and it gives you a lot more stability during the surgery.
At this point, I use just one spoonful, but
I'm relatively young, so I have a lot of accommodation in my eyes. I was a super high myope, so I think because of that, I also have abnormally large amplitude of accommodation. So if I put the microscope in a certain way, I rarely ever need to move it because I can see everything from the posterior capsule all the way up to the cornea. I find these days it's a little less comfortable. Well, thank you so much. I think that goes over the basics. I had a blast on this first day of surgery. We had help from just a very, very tight-knit, experienced crew, and we had Tammy with us, who is our consultant, helping us out, and all the reps from the various companies. It was a beautiful day. I hope you enjoyed this video, and I hope you can see that the OBS, I believe, is just so much more superior, given that we can do bilaterals, we can do things our way, but we have to take the utmost care in sterility. At this point, we should talk about patient on their way out. So we want to, just say hi to the patient afterwards. At DC, I think we're going to be taking a photo. I'm going to be taking a photo with the patient and giving an exit interview before they leave. But the techs at some point around this process should try to get the patient their discharge instructions and just go over it. They should watch the patient do their own first set of eye drops and provide any tips on how to get the eye drops in. Some patients may have, arthritis or something, and you just want to teach them, or they're scared of using the eye dropper. You also want to tell them that the eye drops will sting. Every time they use it, it's going to sting. You can put it in the fridge and cool it down, and it'll be less spicy that way. And if the patient has issues with the eyedropper, you can tell them to just raise their head and chin all the way up, keep their eyes closed, put the drop in the corner of the eye, and then just blink it in. That's okay too. And you want to stress the importance of the eye drops for the first couple of days, because the incisions haven't healed. That's if they're going to get an infection, it's in the first couple of days. Usually it's in the first 1 or 2 days. So being compliant, and it doesn't hurt to do more in the first couple of days, but at least 4 times a day. You want to also tell the patient to always wear the protective eyewear during sleep for the first 4 days or so. That way, if they roll over in bed and they put pressure on the eye, like I said, a side sleeper, it's going to just help them kind of distribute that pressure, so it's not based all over the incision and then the contents of the eye, and the lens will shift place or dislocate. So that, and you want to tell them not to go swimming or have any dirty water come into contact with the eye. Dirty water, obviously a source of infection, so hot tubs, swimming in pools, anything that touches anyone else's, under the neck, or anyone else's any part of the body should be avoided. but running water is fine. They can wash their face when they go home, but just keep the eyes closed. Take a shower, keep the eyes closed. And then I don't have any restrictions on weight bearing or exercise. I think if that lens is going to rotate, it's going to do it in the first hour after surgery, and hopefully they're not exercising in that first hour. But after that, I've had patients go horseback riding the next day. They do just fine with torics. I've actually not had a toric slip in the last 2 years. I've never had to rotate anything. Even ICLs, my own ICLs have been just fine. I think I've rotated other people's ICLs, other things. And then just tell the patient that to expect some more reminders tonight. I usually give the patient a call during the night of the surgery just to make sure they don't have any issues or questions. I really want to make sure our patients are well taken care of, and sometimes they feel shy to call me, so I usually preemptively call them the night of surgery. And for our IQ offices, I'll call them the next day as well, since I won't be in the office, just to check in, make sure they're doing okay. But again, just a reminder, the next day after surgery, while their corneas are clear, they won't have yet adapted to the new way of vision, so they'll say things are pretty blurry. But you check their vision, they're 20/20 J1 plus, yet they'll say it's blurry. But that's the multifocal lens, so they need a good week or so, sometimes even longer for the ring lenses to really get the hang of using these lenses. I mean, we all know people who wear progressives who take quite a lot of time, but this should be much less effort, and they just need time with it for the brain to know how to use it. So just reassure them, things are blurry. That's normal. You're about 80% of the way there. Nobody's ever more than that. And then just reassure them that, you're well ahead of the curve. Give it more time, and things will just get clearer and clearer as the days go by. You can also tell them to expect some of the symptoms right after surgery. So the eyes are dilated. They'll see the edge of the rings, the edge of the lens. They'll see halos and rings because the cornea is swollen. It has nothing to do with the lens if it's a ringless lens, but everybody's going to see halos because of the swelling in the cornea and the dilation. You can tell them that the peripheral vision is going to be foggy. That's because the incisions are made in the peripherally, and because they have two eyes, they have blurriness out of the side of one eye and blurriness out of the other. The brain will just put it all together and tell them all of their peripheral vision is blurry. That's normal. That'll take about 5 days to go away. And it'll slowly go away. And you can just remind the patient, until your peripheral vision is clear, you want to be very, very rigorous with your eye drops. No dirty water around the eyes, because the incisions will have healed once the peripheral vision clears up. You can also remind them that the lens will have this kind of jittery effect. That's because the lens takes time to scar into the tissue around it, to scar into the capsular bag. So the lens will kind of do a little bit of a dance when they move their eyes around. That's completely normal, and that'll all settle out as well. For the same reason, because the lens hasn't scarred in, the tissues haven't come into apposition with each other, that there's going to be a gap between the iris and the new lens. The new lens being about 0.5 millimeter in thickness, the old lens being 5 millimeters. So there's going to be some gaps in the tissue, and they may see some dark arcs or bright arcs off to the side of their vision. That's completely normal as well. Just kind of, if you have time, tell them that seeing bright arcs, dark arcs, flashes off to the side of the vision with the eyes open shortly after surgery is normal. Normal for 2 weeks. Just make sure when they close their eyes, they're not seeing flashes. If that would be concerning if they're seeing flashes with the eyes closed, because that would be, telling of a retinal issue. Anyways, and just congratulate them. Like you always do with LASIK surgery. You did perfect. You're a perfect patient, and offer as much reassurance as possible. A lot of folks like to hear that, and there's the anxiety pill we give them is not that strong. Sometimes you just want them to walk out of the office feeling good about it, and assured that tomorrow things are going to be a whole lot better. It's going to be a different world. Well, anyways, thank you for watching this video, and I hope it helps. This is a unlisted video, so only people will have access to that I share the video with. And I hope our staff will familiarize themselves with the process a little bit more, see why I do things. But hopefully this video gives good explanations for the practices, and things don't seem as arbitrary as the first day that we did it. Thank you very much.